It's my privilege to introduce Professor Giuseppe Spriano, who works at present in the Humanitas Institute in Milan. And there are cases in where then ablative therapies are over. So the surgeon has, we don't forget that we have the surgeon as our friend. And Giuseppe, go ahead with your presentation on advanced thyroid cancer.
Thank you very much, Roberto. It's indeed a great pleasure to be here, and thank you for the invitation. I will try to see this problem of the thyroid cancer in the other side of the river. You know that for those of you that are not involved in otolaryngology world, I was for many years in Varese. Then I moved to Cancer Institute in Rome for 16 years, and then last year I go back to Lombardy to chair the Department of Otolaryngology in Humanitas University. This is the Humanitas University. This is the building of the hospital, the research building, and the university campus. And these are some number of our group. We have more than 100 operating theater, and you see the number of patients and procedure treated. And today, in the ranking of Italian university, Humanitas in the first position for H-index for professor. And this year, Professor Pacini joined us as an endocrinologist. And you have already seen that the incidence of cancer of the thyroid is increased, but mainly for ultrasound effect, in spite of the fact that in some area of the world, because of nuclear disasters, there was really an increase in the risk of incidence. But in spite of that, if you look, the increased incidence is not related with an increased risk of mortality. And so what are we talking about? We are talking on this cancer that is a little bit different comparing to the small tumors that are occasionally diagnosticated in the thyroid. And usually is a differentiated carcinoma, papillary or follicular, that is advanced at the risk level, and all you know, these different acronyms in order to score the different risk for the patients. And this allows us to divide in low risk comparing to high risk, considering patient-related and tumor-related prognostic factors. And there is an official classification that is the TNM system staging by the American Joint Committee that is updated 2 years ago, especially to decrease the concept of T3 when the tumor go out from the capsule of the thyroid. And we have different biological behavior of the tumor, considering the evolution of histology. In papillary carcinoma, you know that there are some variants that are more aggressive, as well as in follicular carcinoma. And usually the tumor start with the benign disease and then go on, and it's like the humans become bad when they become old. And you know that one of the main prognostic factors is the age of the patients, but we can consider that the tumor gets old and bad, but we can modify the age and substitute the age with the color of the hair. We can say that if you are black hair, the prognosis is good. If we have white hair, the prognosis is bad. So it's the same of the age. Of course, if you look at the genomic modification, when the tumor go from left to right, from well-differentiated to poor differentiated and then anaplastic, this process is related with an increasing number of modification in the genome. And usually you see in this slide the more important aspect are the extensive vascular invasion, PT4 with gross extracapsular spread, and PN1 with extranodal extension. So the the first three lines are the situation that are correlated with an higher risk in the oncological outcome. And of course, we can have advanced disease because of distal metastasis. But there is no doubt that the presence of extrathyroid invasion is the main risk factor for recurrence and mortality. And in some papers are divided the minimal extracapsularity with the extensive extracapsularity, and this was on the basis of the changing in TNM classification. And you see that the minimal extracapsular spread is a little bit worse comparing to intracapsular tumor, but the difference is the extensive extracapsular spread that is related with a higher risk of lymphovascular invasion, residual disease after surgery, and plus and decreases in survival. So when we are dealing with thyroid cancer, 80% do well with any surgical treatment, maybe without any surgical treatment. And 5% of them died, regardless of therapy. This anaplastic cancer, you can use surgery, radiation, chemo, immunotherapy, but the patient died. So there are 15% that require an aggressive surgery and radiation. And here, this is the aspect in which the physician make the difference. And if we go back again to prognostic factor, we see that only the MHs from Mayo consider the completeness of resection that is an surgeon factors. We cannot modify this. Tumor-related factors. We cannot modify patient-related factor, but we can modify the surgeon. We can change the surgeon. And so there are some structures that are very easy to be excised, and there is no risk for survival and low risk for function. Then there are some structures that are medium difficult to be excised with, again, low risk for survival and function, but there are very structures that are very difficult to be resected. This summarizes this concept. We have the central neck, the lateral neck, and mediastinum. So easy to be resected, the sternum muscles, recurrent laryngeal nerves, sternocleidomastoid muscles, internal jugular vein. Then there are some structures that are more difficult to be excised, like bilateral recurrent laryngeal nerve, trachea, larynx, hypopharynx, esophagus, and some nerves or sternum on lung. Then there are structures that are very hardly possible to be excised, like carotid artery, thoracic tracheal, and great vessels of the mediastinum. So the concept is to try to remove radically the tumor and to try to preserve the uninvolved structures, but not to try to preserve structures, even if affected by tumors. This is the principle. So we have to avoid HER2 disease. That means to leave in our surgical field macroscopic visible tumor around the structures that are involved. And you know that this is a paper from the group of Memorial, and you see that HER2 is related with a higher risk of recurrence. And this is the curves in which you can see that HER2 is related with a lower survival. these are the structures more involved: recurrent laryngeal nerve first, then trachea, esophagus, larynx, and so on. So some example, this is the strap muscles. You see that the muscles is invaded by the tumor that has an extracapsularity, and this is the recurrent laryngeal nerve. So in this case, we can try to dissect the nerve of the tumor, but in this situation, you see that the recurrent laryngeal nerve is completely encased in the right side by the tumor. So the nerve has to be resected, and hand-to-hand anastomosis has been done. But then when we went to the other side of the neck again, even the left inferior laryngeal nerve was involved. So we had to resect the nerve and to put a graft. But in spite of that, this is the situation of the lady.
Bravo, un'altra.
Both vocal cords are in intermediate position, so the lady was able to swallow and to speak and to breathe even without tracheostomy. And the reason when you cut the nerve that the number of fibers that open the vocal cord are predominant comparing to the fibers that adduct the vocal cord. So if you cut the nerve, the vocal cord will be open. And the invasion of the trachea, we have already seen some slides about that, and probably the concept of unresectability is different in different institutions and in different surgical hands. And you see this is a Shin type 3, that means less than 30% of the circumference of the trachea is involved. So we can resect a part of the trachea, make a window, and to close directly without any problem. So if you leave the tumor attached to the tracheal wall, we will have a recurrent disease, of course. This is another type 4, that is the invasion of the lumen of the trachea, more than 30% of the circumference. So it's very easy to do a resection of the trachea with an end-to-end anastomosis. This is a case of invasion of the trachea for 8 rings. And you see here the common carotid artery, the innominate artery, the subclavian artery, and the recurrent nerve that has been cut. And then we have resected 1, 2, 3, 4, 5, 6, 7, 8, 9 trachea rings. And direct closure, patient was intubated for 2 weeks in intensive care unit. And you see the results with the lumen that is large enough to allow us to breathe the patients. Invasion of the larynx is another frequent organ that can be invaded by the tumor. This is a superficial invasion of the external perichondrium, but this is a deep invasion of the larynx, so a total laryngectomy is needed. And you see here the tumors that spread into the larynx across the cricothyroid membrane, and the invasion of the esophagus. And again, we can resect the external aspect of the esophagus, preserving the inner mucosa, like in this case. But in a more aggressive tumor, we can resect the larynx as well as the hypopharynx and the cervical esophagus. And you see the tumor that is anteriorly and posteriorly to the larynx and into the lumen. A vessel invasion, this is the jugular vein that we can resect with any problem, even partially. And this is the innominate vein. And if you look in this case, it's been opened. There was a thrombus into the lumen. So the thrombus has been removed and the vein was closed through a transternal approach. Carotid artery invasion, again, we can resect a part of the wall. You can see the machine for the neurological monitoring. This is an interesting case. This was a young lady, And you see that internal carotid common was completely 360-degree encased by the tumor. So this is the intraoperative view. I have tried to do a subadventitial dissection, and finally I was able to do that and to separate intact the common carotid artery. You see again the innominate artery and the subclavian one, and the specimen with the shape of the common carotid artery, but the patients had a recurrence or a medullary cancer, and so in the arthroscan was an uptake in the lateral neck. So we went back and we have seen the tumor around the common carotid artery. And so the carotid artery was resected and a prosthesis was put. Then the patient has another recurrence, so we went back again, see the tumor around the subclavian artery, and again the tumor around the common carotid artery, you see here, involving the prosthesis. So we have resect again and put another prosthesis. Many nerves in the neck can be involved, like the vagus one, and you see here the resection, or the sternum invasion. This is a case. You see the invasion of the sternum, the open, the dissection of the soft tissue, and then the detachment of the body from the manubrium with the saw, then the resection of the part of the superior lung, and the cut of the cartilage here, lung here, and the field, and the specimen and the closure. And this is a medullary carcinoma invading the mediastinal pleura. You see here the lung and the resection, and another invasion of the sternum with the resection. A bilateral modified radical neck dissection was done. The detachment of the body from the manubrium of the sternum. And you see here the field, the mammary artery, and the field, the cavity, and here the tumor of the thyroid, the sternum, the neck dissection with the different level in both sides of the neck. This is a mediastinal invasion. You see the superior vena cava syndrome very well with different color. And there was a particular aspect of the aberrant right subclavian artery that is called the lusoria artery. So in this situation, we can already know that the right recurrent laryngeal nerve is not a recurrent nerve, but come directly from the vagus. And you see here in the picture that the recurrent nerve directly go without entry the thorax. And you see again the specimen and the patients. Let's go on some numbers. I was in Cancer Institute in Rome for 16 years, and this was a retrospective analysis on 1,500 cases of thyroid cancer, and we have divided in 462 so-called advanced because of PT4, that were more than 300, or PN1B, that means lateral, that means PN1 neck nodes, or distant metastasis. All homogeneously managed, primary observation without any recurrence tumor. And if you look at demographics, the only difference comparing advanced tumor with the no advanced was a higher incidence in male comparing to female. And if you look at the oncological results, you see that the advanced tumors is this pink curve comparing to no advance, that at 20 here have a survival that is very similar to normal population, and in the middle, both. And you see here the comparison between progression-free survival and overall survival. That is a 15 in difference. That means that we have several patients that with the cancer in their body, but they are still alive. So even in on the palliative aspect, surgery is worth in order to increase 20 years overall survival that can be reached in more than 50% of the patients. If we compare the T4 status, that is the pink one, with the distant metastasis, that is the green line, and the nodal metastasis, you can see that the worst situation is the involvement of neck structures by the tumor. That is more important on the prognostic outcome than distant metastasis. And you know that we have a friend in thyroid tumor that is the nuclear medicine colleague, but of course this works with the well-differentiated tumors. But if you look the group of well-differentiated papillary and follicular tumor, that is this group, comparing to poor differentiated tumor, that means the more aggressive variant of papillary and follicular tumors, like insular, tall cell, and so on, you see that the response to iodine therapy is very different. It's very strong in well-differentiated, very poor in poor differentiated tumors. Another important aspect that we have seen in our review is the number of involved nodes in the extracapsular spread. If considering 77 N1B cases, that means a lateral neck involved, you see the average number of involved nodes more than 6, and so almost 15% of the patients are more than 3 nodes involved, and mainly 2 different levels, and 22 had extracapsular spread. So please remember this number of 17 out of 77, and if we look the recurrence, we have had 13 recurrence, but 10 of them were in patients with extracapsular spread. And so 10 recurrence in the group with extracapsular spread, comparing to 3 recurrence in the group without extracapsular spread. The survival in multivariate analysis, of course, the gender, male versus female, the hazard risk is 3 times more, and neck dissection, no or yes, is significant. Of course, we are dealing with advanced cancer. So the concept that nodal metastasis has no influence in the outcome of thyroid tumors, because the large number of tumors, the majority have low risk, so there is no difference. But if you focus on advanced tumors, so the risk of nodal metastasis is related with its significance. And of course, the poor iodine response has a higher risk of recurrence, as well as the age. This was the old analysis with a cutoff of 45, and the stage of the disease. So the conclusion is that advanced thyroid cancer is moderately frequent, and overall survival is reduced, but acceptable at 10 years, and is low at 20 years, that is about 40%. The morbidity at 10 years is elevated. It means that many patients have the tumor in the body, but are still alive. The radical excision is strongly recommended, never R2. T4 situation is worse comparing to distant metastasis and nodal metastasis. So extended resection is almost always advisable. And the risk factors for progressive disease are age, gender, stage, metastasis, but also neck dissection that is important in advanced cancer, as well end stage, the high risk histological variants, that means poor nuclear medicine response to iodine treatment. So I want again to thank Roberto for inviting me, and I would like to communicate to you that we will host in Milan in 2022 the World Congress of International Federation of Head and Neck Oncological Society that is done every 4 years. So in this Congress will be a large space for thyroid cancer, so all of you are welcome. Thank you very much.
Thank you, Professor. It's a wonderful presentation. And now open for any question or comment from the floor. Oh, okay. Professor, I'm also thyroid surgeon, and I'm so excited to hear about your lecture. And from the view of the super experienced thyroid surgeon you are, could you let me know your opinion about the collaboration with thyroid surgery and thermal ablation therapy? How do you think about it?
Pardon?
I'd like to know about your opinion about indication of the thermal ablation therapy, such as RFA or laser or ethanol ablation. Could give us any...
What means external beam?
Yeah.
External beam irradiation?
If I understood the question is the role of ablation therapies in, well, you've shown clearly out of our influence cases. Did I understood your question?
Yeah.
Role of ablative therapies.
I have heard with interest the previous lecture. I think that the role, especially comparing to observation policy, could be interesting to treat with ablation. So ablation could be in the middle between open surgery and observation. And the second aspect is the last talk that I have heard on palliative intention. Of course, the problem is to understand the limit of the word unresectable tumor, because this word can be different in different institutions. So if you have an invasion of the trachea, this situation doesn't mean incurable disease, doesn't mean unresectable disease. Many surgeons are very afraid when they see the tumor into the lumen, but I think that end-to-end anastomosis with a resection of 3, 4, 5 trachea rings is a very easy operation. It's not a difficult operation, and many surgeons stop themselves when they see a tumor attached to the trachea, and they do a shaving off procedure. So they remove grossly the tumor, leaving intentionally some cells attached to the tracheal wall. This means a recurrent disease, of course, and so we have to go back to resect again. So the message, especially for the young doctors, is try to avoid to leave intentionally the tumor, because many structures like carotid artery, jugular vein, muscles, esophagus, larynx, we have removed thousands of larynx for stage 2 or 3 in the past. And so why not to resect the larynx to do a total laryngectomy when the larynx is invaded by the thyroid tumor? So this is another aspect, because you know that in the world, general surgeon as well as otolaryngologists are involved in this type of surgery. And so sometimes there is a little fighting among them. But the concept is endocrine surgeon, general surgeon, otolaryngologist. The important thing is to remove the tumor off to the neck of the patients. This is the main step of surgery.
Thank you.